Good evening, doctors. This is Chitrakla from Shield Healthcare. This is a webinar conducted by Oxy Reproductive Health Committee. The topic of today's session is resistance PCOS and ovulation induction. For this, I heartily welcome our coordinator, Dr. Aruna Ashok ma'am. Dr. Aruna Ashok ma'am is a clinical director and senior fertility consultant at A4 Hospital and Fertility Center. Ma'am has 17 years of experience in the field of fertility, and ma'am is a speaker at various international conferences and doing research for improving fertility success rates. Ma'am is a guide for fellowship course in infertility and training the young doctors. Ma'am is an executive committee member of TAPISA and advisory board member of FAME. Handing over the session to ma'am. Welcome, ma'am.
Yeah, thank you. Good evening to all. On the behalf of Reproductive Health Committee of Oxy, I have immense pleasure in inviting the chairperson, Dr. Angamal. She is very passionate about treating the patient, and every time which she has a difficult situation, she has a dedicated work of discussing as a team. And from Kanjipuram Obstetric Society, which is a very academically strong society, she had been a president of the society. So she is a consultant gynecologist for past 18 years with a passion for preventive oncology focusing on cervical cancer and master trainer in HPV vaccination project South Zone. She's a consultant at having a private practice in Kanchipuram. She has done her MBBS from Salem and she's MD from Stanley. And over to you, madam. I think many of your questions and your doubts will get answered with the speaker. Over to you.
Thank you, madam, for your kind introduction. And thanks for involving me in this awesome webinar, madam. I'm immensely privileged to introduce today's speaker, Dr. Nagori sir. Sir, we all know he's the pioneer in the infertility practice in our country. And as well as he's Dronacharya for so many practitioners who is practicing infertility across the country. Thank you, sir. And I'm immensely blessed and privileged to introduce you in this webinar. Sir is director of Dr. Nagori's Institute for Infertility and IVF, Ahmedabad, India. He had his best paper in World Congress IUCG 2008 Chicago. He is the one who did the first stem cell pregnancy in India. He also has the first ever Center of Excellence for Ian Donald School of Ultrasound. He holds regular trainings in infertility, IVF, and ultrasound. Also, he holds Gujarat University recognized fellowship programs in infertility and IVF. Sir has published several papers in index journals, as well contributed in and authored several books. Thank you, sir, and expecting your LI speech now. Over to you, sir.
Thank you very much, chairpersons and Aruna. I'll be discussing about the ovulation induction in PCO. Yes, can you see the slide now?
Yes, sir.
Yes, okay.
Yes.
See, when we see the patient as a PCO, the most important test what we should undergo, there are two different tests. One is the glucose tolerance test and second is the 3D sonography. So majority may not be having the 3D ultrasound. So first I discuss about the glucose tolerance test, that you measure the glucose level and you measure the insulin level of the patient. Give to 75 grams of the glucose and after 2 hours you measure the glucose level as the insulin level. Now, in majority of the PCO patients, the insulin level will jump to 100 to 150, and in severe insulin resistance, you may be more than 300. This is most common in thin, lean PCO patients, where surprisingly you will get the insulin resistance more than 300 mu international unit. So, this test is very important because you have to stem the patient as PCO. The reason is that how this test can help you, whether the drilling is to be done to the patient or not, whether antagonists are required for the patient or not. So these all will depend on the insulin resistance. Many times it happens that the ovary looks like PCO and the drilling has been done, but unless it is mentioned on the case paper about the 3D sonography, what is the stromal volume and what is the ratio of the stromal volume to an ovarian volume, or the 2-hour insulin resistance test has been done, drilling should never be done unless it is documented PCO. Now, all of you know that ovulation induction in PCO, there are various remedies available to us, and first is always the weight loss. It is always the first line of treatment, and here the joint efforts are required. Means you have to take the help of the dietitian, you have to take the help for the exercise also. So all an endocrinologist also. So it is a joint effort that should be done. Women with PCOS are more obese than their non-PCO counterparts, with 50% having BMI over 30 kilogram per meter square. Now, how much should be the weight loss? 5 to 10% of the weight loss is important for the ovulation. It reduces about the 30% of the visceral fat due to increased lipolysis and high metabolic activity. This regains reproduction function in 60 to 100%. Now, it is very easy to tell to the patient that you just get the weight loss and we can discuss the treatment of PCO afterwards. But it is extremely difficult to have the weight loss. And that's why off and on in during all the visits, the weight loss should be emphasized to the patient, as well as you may have to contact the dietitian, you may have to advise for the regular exercises, then and then there will be a weight loss. But if you explain that you don't require to weight loss much, you require only a 5% of the weight loss. So majority are between 60, 70 kg, and 5% will be only 3.5 kg. So you explain them thoroughly well, they will be always ready to reduce about 3 to 5 kg weight. National Health Services fertility treatment requires BMI less than 30. So this is an incentive. Those patients who want to take the free of charge treatment from the NHS, then their weight should be less. This is, I think, one of a very good idea the NHS has got. All the studies showed that the higher recovery of oocytes, but the lower fertilization rate and higher abortion rate with an obese patient. So the pregnancy may occur in the obese patient, but it is always difficult. The quality of the oocyte may not be good, and the abortion rate may be very high. Normal BMI 20 to 24.9, overweight is 25 to 29.9, and obese patient will be 30 kg per meter square. Women in a normal weight may not benefit with the weight loss. So, if the BMI is normal, then there is no need to tell the patient about a weight loss. The patient does not get any benefit out of it. Majority of the patients, they come and tell you in your OPD that, sir, I am having PCO. So they have so many wrong concepts about the PCO, and they always believe that their obesity, PCOS does not cause the obesity. They always feel that the obesity is because of PCO, but they should be told that it is other way around. PCO never causes the obesity. Obesity may exaggerate the PCOS. Anti-obesity agents. It is considered as an experimental therapy, and it is too uncertain to advocate as fertility therapy. So anti-obesity agent should not be given when you are treating the patient for fertility. For a weight loss or for all other purposes, you may apply for it. But and this is also 2023 guideline also agreed that the anti-obesity drugs are experimental therapy and should not be advocated for the fertility therapy. Bariatric surgery. It is considered as experimental therapy and it's too uncertain to advocate as fertility therapy. 2018 as well as 2023 guidelines both have the same concept that BMI more than 50 kg per meter square, the bariatric surgery is the first line of treatment. But if the BMI is less than 50, then the bariatric surgery should not be advocated. When the patient has undergone bariatric surgery, the pregnancy is avoided for at least 12 months. And during pregnancy, nutritional deficiencies are very common, and that's why there should not be any pregnancy during the first 12 months. So bariatric surgery, extremely obese patient, BMI more than 50, then it is indicated. This 2018 and 2023 guidelines are more or less the same. I've included this 2018 for prevention of a weight gain, 5 to 10% of the weight loss should be achieved. Same is in 2023 also. And energy deficit of 30%, that is 500 to 750 kilocalorie per day, that is 1200 to 1500 kilocalorie per day should be prescribed. Flexible diet and individualized approach is required. That's why energy deficit of 30% should be there, then and then there will be a weight loss. And you can have 5 to 10% of the weight loss. Patient can lose the weight almost about 1 to 1.5 kg per month, maximum up to 2 kg. More than that is not possible in majority of the patients. And that's why it may take few months to reduce the weight also. For modest weight loss, 250 minutes per week of the moderate intensive exercise. Otherwise, 150 minutes per week of the vigorous exercise. For maintaining the weight, you may have 150 minutes of a regular exercise. That is 30 minutes per day and 5 days in a week will be enough. But if you want to have a modest weight loss, then it should be a vigorous 150 minutes exercise, or you may double. Instead of 30 minutes, you can go for 60 minutes for 5 days, and that will give definitely the weight loss. Combination of both with the muscle strengthening twice a week or daily 10,000 steps of walking is ideal with the 30 minutes of structural activity or 3,000 steps extra. So either you combine your muscle strengthening exercise plus 10,000 steps, or you can go for 13,000 steps. That will definitely decrease the weight loss. SMART, that is specific, measurable, achievable, relevant. This goal should include the 10 minutes bouts with 5% weekly physical exercise. Now, decrease in subcutaneous fat does not resume the ovulation. Intra-abdominal fat reduction is necessary, and that's why there are two groups of patients. Some patients always lose the weight, but they do not resume the ovulation because most of the weight loss is because of the subcutaneous fat. While there are some patients where the external appearance may be the same, but they get the weight loss because 30% of the abdominal fat is reduced, and then they resume the ovulation also. Now, second drug is the clomiphene citrate. Of course, clomiphene is not recommended in the either in 2018 or 2023 guidelines as the first line of treatment. First is always the letrozole, but the clomiphene has got the place also. Clomiphene is normally given 50 to 100 milligram for 5 days, and whether you start it from day 2, day 3, day 4, day 5, the pregnancy rates are same. Clomiphene should not be given more than 100 milligram because the pregnancy rate is less than 10%. And that's why 100 milligram is the maximum dose that can be given to the patient. Now, when you give clomiphene citrate, particularly in a PCO patient, day 8 or 9, LH should be done. And when, because the clomiphene acts on the hypothalamus, it increases the FSH and LH. And when the LH is more than 10 international unit, it reduces the conception rate and increases the abortion rate. So when the LH is more than 10 international unit on day 10 or up to day 8 or day 10, then you should switch over to the other therapy rather than continuing the clomiphene in the next cycle. Clomiphene versus clomiphene plus gonadotrophin have insufficient evidence whether one intervention is better than the other. Clomiphene should not be combined with gonadotrophin. The reason is that clomiphene acts on the hypothalamus, it increases FSH and LH, and this high LH is detrimental to an ova. And now this high LH and you are adding HMG, so you are adding more LH to the patient. So LH will be excessive, which will be detrimental to an ova, and that's why clomiphene plus HMG or clomiphene with FSH also is not advisable because the quality of the follicle which has been destroyed because of the high LH, because of clomiphene, cannot be rectified by giving FSH, either highly purified or recombinant FSH. So clomiphene plus gonadotropin is a very bad combination, should never be used in practice. I've seen so many prescriptions that even in a PCO patient where the LH level is already high, then the HMG should not be given to the patient. On clomiphene plus HMG is the worst combination as far as the PCO is concerned. You can give only gonadotropin and that too also the FSH only instead of HMG or instead of clomiphene. Clomiphene can be used for ovulation induction. Even in 2023 also it is added. Metformin can be used to improve the ovulation, but the woman should be informed that the better drugs are available. So metformin can be used, but the better drugs are available, and that's why metformin is never preferred for the ovulation induction. In obese PCOS, CC plus metformin, CC is always preferred. So SRM guidelines that if metformin is used in obese PCOS, CC can be added to improve the ovulation, and metformin should be combined with CC when the CC resistance patients are treated, and risk of the multiple pregnancies is increased because of the clomiphene. Now, this is very important that particularly the role of metformin is only when there is CC resistance. So you have given already 100 milligram of clomiphene citrate and the patient does not ovulate, then you can combine metformin. But if the patient ovulates with clomiphene citrate, then metformin has got no role. If the ovulation occurs with either 50 or 100 milligram of clomiphene citrate, by adding metformin, you do not improve the pregnancy rate. Pregnancy rate remains the same if the patient ovulates, whether you are giving only CC or CC plus metformin. That's why metformin should only be given to those patients who are CC resistant patients. Now, one more thing I would like to tell you about this, that when there are a lot of patients who come to a gynecologist and tell that we don't want pregnancy for 6 months or 12 months. I think these are the ideal patients where the metformin can be given to the patient. It will establish the normal homeostasis. And when the patient wants a pregnancy, there may be a spontaneous ovulation or they may have an oral ovulation can ovulate the patient. That's why metformin is required as a two indication only. One is the CC resistance who want to conceive. And second is those who don't want to conceive, then you can start metformin for a few months. And when they want a pregnancy, then you can reassess once again the patient. Then third one is the letrozole. Letrozole will be considered as the first line pharmacological treatment for ovulation induction in PCOS with anovulatory infertility. Even the latest 2023 guidelines also tell that the letrozole should be considered as the first line of treatment that should be considered. Now, the mechanism of letrozole, that letrozole causes the hypoestrogenism, that is, androgen is not converted into estrogen, and that is why there is hypoestrogenism. And this hypoestrogenism, at the hypothalamus, there is a negative feedback, and FSH and LH are secreted. This is same like clomiphene citrate, that there is an hypoestrogenism, and that is why the FSH and LH both are secreted. Now, when the follicle develops, the estrogen goes back to the hypothalamus. Here, receptors are not occupied. They are occupied in clomiphene citrate. They are not occupied in the letrozole, and that is why the FSH and LH will decrease. So, this is the very important thing that LH will decrease. So, the quality of the follicle will not be spoiled. FSH will decrease, and that's why it will give a monofollicular development. So, letrozole, because of its the androgen is not converted into estrogen, and that's why it is much beneficial drug than the clomiphene citrate. Second advantage of letrozole is that there is a temporary rise of androgen. That androgen is not converted into estrogen, and that's why there is a rise of androgen, and there is a level of estrogen goes down. So this rise of androgen sensitizes the follicle to the lower dose of FSH. See, in a poor responder, we are giving DHEA. In a poor responder, we are giving androgen gel also. So all these androgen which are given in the treatment are to sensitize the follicle so that the lower dose of FSH can stimulate the patient. And that's why there is an advantage of letrozole that it requires the lower dose of gonadotrophin for the stimulation. So there is a monofollicular development, less multiple pregnancy rate, reduced chances of OHSS. Pregnancy rate increases by 40 to 60% with the letrozole as compared to the clomiphene citrate. Now, letrozole improves the implantation. PCOS, there is a dysfunctional endometrium. Estrogen receptors in the endometrium do not reduce in mid-secretory phase, leads to progesterone resistance. So, anti-estrogenic agents improve the implantation. Also suppresses the action of ER alpha and the positive impact on the endometrial expression of the AV beta 3. So this improves the implantation, and that is why letrozole is a very good drug. Now, there are some regimes which are given in the literature that the extended letrozole therapy, 2.5 milligram letrozole is given from 1 to 10 days. And CC-resistant PCOS patient, it may produce more follicles and may give a better pregnancy rate. This was the study by Badway in 2009. I would like to inform you that there are no further studies available on this regime after 2009. So this is not accepted nowadays. It's not a good regime. I'll tell you why the reasons, but after 2009, there are no papers available to this. Then another protocol that has been written in literature is letrozole step-up protocol, that 1, 2, 3, and 4 tablet, 2.5 milligram on day 2, day 3, day 4, and day 5. This causes multifollicular development and the higher pregnancy rates. Longer duration of expressed exposure, prevention of the estrogen secretion, granulosa cell, so estrogen does not rise and FSH does not get suppressed. Now, this was also the paper in 2008, and afterwards there are no papers available on this regime, and that's why this regime is also not to be used. Many a times this is written by the people, but these are very old papers, almost about 15 years old paper, and afterwards there are no research available on these studies, and that's why they are not useful. Now, in both these regimes, the actual advantage of letrozole, unnecessary exposure of the ovum to the LH and monofollicular development is lost. Here you get multiple follicles by this regime, 1 to 10 days or 1, 2, 3, and 4 tablets on day 2, day 3, day 4, day 5. And here you get multiple follicles. So, and second thing is the monofollicular development is lost, as both these lead to longer duration of FSH and LH secretion and multiple follicular development. So longer duration means LH will be more, and LH will be more, which will be much detrimental to an ova. And therefore, larger and the robust studies are required to accept this protocol in the routine practice. So these are not accepted in the routine practice. Then the third regime which has been recommended is letrozole plus clomiphene in PCOS, because both have the different mechanism of action. Now, letrozole 2.5 milligram and CC 50 milligram from day 3 to 7, 34% more ovulation than the letrozole alone. No difference in pregnancy rate, abortion, ectopic pregnancy, and multiple pregnancy rate. There is no difference in endometrial thickness and serum progesterone and serum LH level. Now, the disadvantage of this is that you have already given clomiphene citrate, which acts on the hypothalamus, increases FSH and LH, and the lower pregnancy rate in PCOS is because of the high LH. And here you are giving once again along with letrozole CC, so you are increasing the LH level further. And that is why the quality of the follicle will be spoiled, and that is why the pregnancy rates will be poor. So there is no difference in the pregnancy rate, and that is why the combination is also not to be used in practice. Now, there is a last paper in 2023. This is a very promising paper which has come for the resistant PCO patients, that you give 5 milligram, that is given for 5 days. And there is no ovulation in the next cycle only. 5 milligram is given for 7 days. If there is no ovulation, then 5 milligram is given for 10 days. Now, how this regime differs? See, all of us know that the letrozole is always started from day 3, and day 3, 4, 5, 6, 7 it is given. All the drugs for ovulation induction for IUI cycles are started from day 5, and for IVF they are started from day 2. Now, while letrozole instead of day 5, it is started from day 3. The reason is that by the time 3, 4, 5, 6, 7, from 7th day onwards, the level of letrozole will go down. And as the follicle develops before fertilization, it is out from the circulation. Otherwise, letrozole is an embryotoxic drug also. It is an anti-cancerous drug. And that is why the high level of letrozole may remain inside the circulation. That is why the higher doses are not welcome for ovulation induction with letrozole, and the longer duration also not useful. Now, here in this case, the ovulation does not occur. So there is no question of embryotoxicity. And that is why you can give it in the next cycle for 7 days. And if no ovulation occurs, then you can give it for 10 days. So even though it is given for a longer time, it always vanishes from the circulation before the follicle develops. And that is why it is for a resistant PCO patient who cannot afford gonadotrophin, who cannot afford ART. These are the right patients where you can try ovulation induction with 10 milligram, 5 milligram for 10 days. Otherwise, in a routine practice, the letrozole is always given as 2.5 milligram. Here, the higher dose is better than the longer duration. It avoids the multiple pregnancy. It is useful in subgroup, that is the resistant PCO patient. Premature LH surge and spontaneous rupture of the follicle is likely. Waiting for the spontaneous surge gives the better endometrium to the patient. Only thing is that the high LH is detrimental. This is a retrospective study which requires the further validation. The disadvantage of all this regime is that the main advantage of letrozole monofollicular development is lost. FSH and LH both will be secreted for a longer duration, and this high LH is detrimental to an ova. This is the disadvantage of CC2. Larger trials are required before using this regime in clinical practice for few treatment cycle. So the consensus is that the letrozole should be used from 2.5 milligram for 5 days only. The higher doses, that is the 5 milligram doses, are also not required because the suppression of estrogen almost in 97 to 99% occurs with 2.5 milligram only. Very rarely you require 5 milligram. And second thing is, nowadays the letrozole SR tablets are available. But if you see, the biological half-life of letrozole is 48 hours. So what is the use of SR tablet when the biological half-life is 48 hours? So that is also the useless drug. You should give only 2.5 milligram letrozole to all the patients. The letrozole should be considered, even in 23 guidelines also, the letrozole should be considered as the first line of ovulation induction in PCO. Letrozole resistance is less than CC. The risk of multiple pregnancy is also less. Then comes the insulin resistance. Insulin sensitizes, decreases the hyperandrogenism even in the non-obese patients. So it corrects the abnormal insulin action or by decreasing the insulin level. Meta-analysis, this is a very good study by Legro and Moll. This is one of the largest study in the literature that the metformin has got the lower birth rate. So I told you previously also that if the clomiphene causes ovulation, then adding of letrozole does not add to the pregnancy rate. So that's why the metformin is not preferred for ovulation induction. Always the clomiphene is used for ovulation induction. Adding metformin does not lower the dose of the CC. Finding of the two randomized controlled trial, that is Legro and Moll in New England Journal of Medicine, the metformin does not increase the live birth rates. Metformin is not better than the placebo for the pregnancy rate, multiple pregnancy or the abortion rate, and it is added in CC-resistant cases only. So all these guidelines up to 23 also, it says that it is to be used for the of CC-resistant cases only. Metformin in PCO should be restricted to the woman with glucose tolerance and frank type 2 diabetes. Patient-tailored approach should be developed for ovulation induction. Efficacy is not dose-dependent, but the side effects are always dose-dependent, and it may cause the low B2 level also. Metformin, in addition to lifestyle management, could be recommended to adults in the woman with PCO for the treatment of weight, hormonal and metabolic derangements when BMI is more than 25. This is 23 guidelines. So metformin is not for the fertility treatment. Metformin is much more for the metabolic derangements. It is more useful for the patients. Addition of metformin to gonadotrophin has no advantage in improving the ovulation rates, pregnancy rate, live birth rates, multiple pregnancy rates, and incidence of OHSS. So that's why metformin is not much useful. But the current evidence favors the combination of CC in the resistant cases. In prospective randomized controlled trial, no difference was seen in metformin and non-metformin group in IVF patients. In a patient with PCOS and the poor ovarian reserve, metformin worsened the response to gonadotropin and it should be stopped before starting the controlled ovarian hyperstimulation for IVF. This is a very important statement because the metformin is used for the prevention of OHSS. It means it regresses the number of follicles. And that's why if empirically, if the metformin is given to all the patients before the stimulation, because nowadays in IVF, we always freeze all the embryos and transport in the next cycle. And in this patient, if you start metformin, then it will reduce the number of follicles that you get. That's why please don't give metformin to a patient where you are going to stimulate the patient, you are going to do the pickup, freeze the embryos and transfer in the next cycle, that is segmentation of IVF. Then the metformin should not be given because it will reduce the number of eggs what you will be getting. In the meta-analysis and evaluation, the effectiveness of the metformin as a co-treatment during IVF cycle in the patient with PCOS, metformin reduced the risk of ovarian hyperstimulation syndrome by 75%. But nowadays, I think with an antagonist cycle, with the agonist trigger, we always freeze the embryos and transfer in the next cycle. And if you are going to transfer, then there is no point in giving metformin to this patient. So these were the papers when we did not have antagonist. We had only agonist in the market, and then we used to give metformin to the patient. Nowadays, we never give metformin for the prevention of OHSS because we are giving an antagonist and we are giving agonist trigger, freezing all the embryos and transfer in the next cycle. This is one of the paper have shown that the insulin has direct toxicity to the human placenta, and so the continuation of metformin may be beneficial during pregnancy and prevents the pregnancy loss. This is a very current paper. Further papers are required. There is always a controversy whether the metformin is to be continued during the pregnancy or not. But in a patient of recurrent pregnancy loss, by giving metformin, always you can reduce the number of pregnancy losses. And this is the paper which tells that it directly has got an action on the human placenta. And that is why the metformin is to be continued. So metformin is normally continued in the earlier pregnancy for the prevention of the early losses for up to 9 weeks of pregnancy or up to 12 weeks of pregnancy. The metformin is to be continued particularly during the pregnancy. Metformin alternatives, insulin sensitizers like pioglitazone, rosiglitazone, acarbose, dihydroinositol. I think this was the same in 2018 guidelines also. In 2023 guidelines also, it has been mentioned that the metformin alternatives are still experimental. I think maximum usage of insulin sensitizers are used for ovulation induction in PCO patient. They have never been found to be better than metformin. And second thing, still they are considered to be an experimental. So metformin, SRA-SRM guidelines, metformin does not give good pregnancy rate. It is added in CC-resistant cases, particularly when BMI is more than 30. It reduces the OHSS in a dose of 1500 milligram, particularly when you want to go for a fresh transfer, and other insulin sensitizers are still considered as an experimental therapy. Now, glucocorticoid. Oh, sorry. It is a wonderful drug, glucocorticoid. I'm sure that very few gynecologists are using glucocorticoids in the regular practice, but we have practiced in an era before the metformin was invented, and nothing was available to us. At that time, we had only dexamethasone and the clomiphene citrate, or the glucocorticoids were available to us. The main advantage of glucocorticoid that it suppresses the ACTH nadir, and that is why the androgen level will be decreased. When you decrease the androgen level, that will decrease the LH level. And when you decrease the LH level, FSH-LH ratio is automatically reversed and you get the spontaneous ovulation. So dexamethasone is a drug of choice. It is given continuously for 3 to 6 months. And particularly those patients who are resistant to clomiphene for 100 milligram, then instead of increasing the dose of clomiphene to 150 to 200 milligram, which has got a very low pregnancy rate, instead of that, you can give the dexamethasone to the patient 0.5 milligram at night, and that will give a very good ovulation induction. So it is very useful in chronic anovulatory and resistant PCO patient. That should be used for the patient. Now, it is very useful when DHEA is high or marginally high DHEAs, which is common in PCO, and that's why dexamethasone will be a very useful drug to the patient. Gonadotrophins, it is always a second. So first line of treatment is letrozole. Second line of treatment is gonadotrophin is used as the second line of treatment in anovulatory PCOS who have failed with the first line oral estrogens. It can be considered as the first line of treatment in the presence of ultrasound monitoring and after counseling for the cost and multiple pregnancy. Gonadotropins are preferred over CC plus metformin in CC-resistant anovulatory PCOS. Gonadotropin is always given the higher pregnancy rate. Gonadotropin should be combined with metformin in resistant cases. Either gonadotropin or ovarian drilling should be used after counseling. So second line of treatment is gonadotropin oblique counsel, oblique ovarian drilling. So either you can go for gonadotropin or you can go for ovarian drilling. Those who can afford, those who don't want to avoid surgery, you can go with the gonadotropin. Those who cannot come to you for off and on for follow-up of the patient or who are poor patients, then you can always go for ovarian drilling. The pregnancy rate of 6 months of gonadotropin and 12 months of ovarian drilling is the same. And that's why ovarian drilling is a wonderful procedure for the non-affording patients. Now, there is always which gonadotropin is to be used. Now, the FSH which is secreted after the menstruation is having a very poor bioactivity and it is larger in amount, while the FSH which is secreted during the periovulatory period is smaller in amount and is having the highest bioactivity. So, the bioactivity and immunoactivity of the FSH are not the same throughout the cycle. And bioactivity increases during the periovulatory period. And the recombinant FSH is prepared from a Chinese larva in such a way that the bioactivity mimics the periovulatory FSH. And that is why the recombinant FSH has been found always better. Now, if you see the specific bioactivity, the HMG has bioactivity of 8 international unit, urinary FSH 100 to 150. Urinary highly purified HMG has got 2000 international unit. Urinary FSH highly purified has 9000 and recombinant FSH has 10,000 international unit. So in practice, you should always go for highly purified FSH or recombinant FSH, particularly for the stimulation protocol. Either it is your conventional protocol for IUI or for IVF. But unfortunately, we have seen a lot of prescription. I think perhaps that people are using HMG more for the stimulation protocol in a PCO patient also. But remember, when you give HMG, you are giving LH to the patient. LH, which is already high in a PCO patient, by adding more LH, it will cross the ceiling level and that will spoil the quality of an egg. So HMG is never preferred in a PCO patient. There are only few indications which I will discuss afterwards, but routinely you should give always FSH to all the patients of PCO for the stimulation protocol. Now, meta-analysis of the 8 randomized controlled trial comparing recombinant FSH and HMG has shown that recombinant FSH has 50% higher pregnancy rate than HMG. The FUNET report 1999 showed that the pregnancy rates were higher with recombinant FSH than HMG. And prospective analysis of 24,000 ART cycle from Germany also showed the higher birth rate and lower dosage with recombinant FSH than HMG. So particularly when the recombinant FSH came in the market, then all the trials have done that recombinant FSH has given the higher pregnancy rate and the dose required of recombinant FSH is also lower because I already discussed the bioactivity. Bioactivity is very high than even the highly purified HMG, and that is why the recombinant FSH is always preferred. Now, in a PCO patient in an IUI cycle, how you should stimulate the patient? Normally, a chronic low dose protocol has been discussed in the literature that you start either with 37.5 or 75 international unit and you give it for 10 to 14 days. Now, here, the most important thing, and this is Professor Ramberg paper, that you have to give it for 14 days. And particularly when you give it for 14 days, most of the time you are tempted to increase the dose in between. And if you increase the dose, Before that, all of a sudden you will get multiple follicle on both the sides, and you may have to convert your IUI cycle into the IVF cycle. But if you continue the dose up to 14 days, and if there are no follicle or no endometrial improvement, then you increase the dose 50% of the original dose. So if it was 75, then you increase to 37.5 and give for another 7 days. By day 21, almost in all the cases, you will get a very good follicle. Or you may have to continue further by still increasing the 50% of the original dose. This chronic low dose protocol is safer and conventional than the conventional protocol. I tell you that with this protocol, the pregnancy rates are excellent. Uh, PCOS is never considered as an indication of IVF. Here there is a defect of ovulation, induction, and that's why you have to ovulate the patient very well. Chronic low dose protocol is very good. I can give you one example of one of my patients who was stimulated with the gonadotrophin. Unfortunately, that PCO patient got hyperstimulation. Unfortunately, that some complication occurred in that patient, and the laparotomy was done, and the one ovary was removed. That patient came to me. That was a classical PCO patient, and we started with chronic low dose protocol. In a second cycle with IUI only, the patient conceived. So what I want to emphasize that the PCO is never the indication of the IVF. It is always the indication of IUI. Chronic low dose protocol is safer than conventional protocol, and this is Professor Rambach paper that instead of CC, the FSH should be the first line of treatment. Gonadotropin has got the higher pregnancy rate than the clomiphene cited. And this was the paper which was by Roy Ambach. This was the initial study, and was found out that it gives the higher pregnancy rate. And this was the paper which was presented and published also afterwards in Human Reproduction. This was presented in the Spain ESHRE conference, comparison of clomiphene versus FSH. And here you can see that the clomiphene has given 25, and those who failed with clomiphene, 34 patients give with the conceived with the FSH. But if you give FSH only and CC, then the pregnancy rate is almost double. That is CC with 25 pregnancies and with FSH 50% pregnancy. So there is always a clear superiority of the low dose FSH over clomiphene for the first line treatment for anovulatory PCOS. And chances of clinical pregnancy in the first cycle is 30% as compared to 15%. After second cycle, 50.7% versus 32.5%. These are all figures of Professor Rambach in his paper, that the low dose FSH is always better than the clomiphene citrate. Only thing is the ease of administration may be high, but if you consider the cost, you may feel it better, but there are a lot of patients who are coming from outside. They leave their job, or they take the leave from their job, transportation expenses. If all the things are considered, then you will realize that the low dose FSH is much superior than the clomiphene citrate. We have found low dose letrozole plus recombinant FSH as a very good combination. I think I am using this combination since so many years, that it reduces the impulse of recombinant FSH, and it gives more or less a monofollicular development, or hardly 2 or 3 follicles you get with this protocol. You start letrozole from day 3 to 7, and by day 7, the letrozole level starts decreasing. Estrogen has already given the follicle, so it reduces the FSH and LH, and particularly the LH decrease will improve the quality of the follicle. FSH decreases, so at that time you can combine recombinant FSH from that day by giving just 2 to 3 ampules only. You will get 2 to 3 good follicles, and your IUI pregnancy rate will be very high. So letrozole plus gonadotropin is an excellent combination, and that gives a very good pregnancy rate. There are some papers which tells that recombinant FSH, urinary FSH, or highly purified HMG have got the same pregnancy rate. But if you see the majority of the papers, they always tell that the required dose of recombinant FSH is always lower then the urinary FSH or the highly purified HMG. And if you see the bioactive, so these are the papers, many a times they are company-oriented papers. But if you see the physiology will tell you correctly what is to be used and what is not to be used for the patient. Routine use of metformin before or during the stimulation is not recommended uh, with the PCOS in antagonist protocol also. And with metformin, less number of eggs are retrieved. So when you start gonadotrophin, please don't combine it with the metformin. Now, this is an ultrasound-based decision-making on stimulation protocol for IVF. This has been published in the journals also, and we follow this protocol since long, almost 2016. Here we consider age of the patient, BMI of the patient, total AFC of the patient from both the ovaries, mean ovarian volume, stromal RI, and stromal PSV. So if we take the 6 parameters and then we give the score 1, 2, 3, 4, and 5. And accordingly, we give the score to the patient. Just I give an example that suppose the patient's age is between, that is a 30 years. So here, what is 30 to 35 years, then suppose it is 3. Suppose the BMI is 30, then it will be 2. Then suppose the AFC is 15, then 3. So 3 plus 3, 6 and 2, 8. Suppose ovarian volume is 3, then it will be 10. And stromal RI is suppose 0.75, so it will be 12, and PSV is 5, then it will be 15. So here the total score will be 15. And we have got that, so what should be the starting dose for IUI, for IVF, and for freezing cycles? So here you calculate, and according to this 15, you can start with 112.5 units and 300 units in IVF. So what I want to emphasize is that higher the score, the lower dose is started. And when the score is low, then the higher doses are required for the patient. And we are following since this more than 7,000 cases we have already done on this, and it is giving very promising results. It has been published in Human Reproduction also. The ESHRE ASRM recommendations. Gonadotropins are the second line of treatment in PCOS after letrozole. Gonadotropins can be considered as the first line of treatment after counseling, as it has very high pregnancy rates. These are better than CC plus metformin for improving the ovulation rate, pregnancy rate, and live birth rates. Gonadotropin is combined with metformin in resistant cases, but I told you that if you are going to do a fresh cycle, then it should never be combined. Ovarian drilling should be given as an option. Low dose gives monofollicular development. GnRH antagonist. GnRH antagonist, the excellent results with GnRH antagonist, particularly when in an IUI cycle, when the follicle is 14 millimeter size, this prevents the LH surge and pregnancy rate is improved, particularly in the thin, lean PCO patients. So, in a thin, lean PCO patient, the androgen level is high, and that's the reason that the LH level will be high. And this high LH will immediately give the LH surge when the estrogen level rises. So, when the follicle is 14 millimeter, you can start antagonists that will suppress the LH surge, and then you can give either HCG or agonist as a trigger can be given to the patient. Progesterone for LH peak suppression. Progesterone administration along with the whole stimulation maintains the pituitary suppression and has shown to prevent LH surge effectively, in which the GnRH protocols are not used. Nowadays, we all are using antagonist protocol, particularly even if you want to freeze the cycle or you want to go for the fresh transfer. But now, if you want to freeze the cycle, medroxyprogesterone acetate 10 milligram per day, starting from day 2 onwards. Some people are starting from day 5, some are starting from day 6. But in a PCO patient, if it is started from day 2, it definitely prevents the LH surge, and you can save lots of money of the patient, because you require about 5 to 7 antagonists per cycle, and it will be as good as 10 to 15,000 rupees saving on the part of the patient. If you give this is known as the progesterone prime ovulation induction. So Progesterone prime LH surge can be prevented, and this can be used, and you freeze all the embryos and transfer in the next cycle. We are routinely now giving this to our PCOS patient because we freeze the embryos and transfer in the next cycle. That's why this will be working very good. So even if you want to go for your PGS, PGD, then also you can give progesterone 10 milligram, medroxyprogesterone acetate daily for 10 days or till the day of HCG that is to be given. There is no difference in pregnancy rates and the number of oocytes retrieved. Then the progesterone for the suppression of LH peak is it may be used in a non-transfer. So I told you that in a frozen cycle it can be used. For the fresh cycle it cannot be used. Antagonist can be used in a mild stimulation. It can be used in modified natural cycle with agonist trigger and the freeze-all, or you can use it. It completely abolishes the OHSS because you start antagonist in an antagonist should be continued in an established OHSS also because it will suppress the LH, it will decrease the estrogen level also. Androgen is not converted into estrogen, and all the complications due to high estrogen can be prevented by continuing antagonist therapy to the patient. Orally acting antagonists are under the relugolix has come in the market on an experimental basis now, and it is available in Western countries. But relugolix, that is an orally acting antagonist, is very useful, particularly when you want to do a fresh transfer. And the only disadvantage is that it takes more hours than the 6 hours taken by the injectable. Well, here it takes about 14 to 16 hours many a time to suppress the LH surge. And that's why the orally acting antagonists are started quite earlier. But it can be used in a fresh transfer patient. While progesterone prime ovarian stimulation is normally done when you want to freeze all the embryos and transfer in the next cycle. GnRH agonist down regulation nowadays is almost the history. I would say that since so many years, I think more than 15 years, I have not used, 15 to 20 years perhaps, I have not used agonist down regulation to any patient. Agonist down regulation that will, um, for the good cohort of the follicle, or those who want to go for the batch IVF are still using GnRH agonist. But you can get a very good cohort of follicle by starting estradiol valeriate from day 21, and you continue till the day of the stimulation. And those who are doing a batch IVF, then you may stop it at day 2, day 3, day 4, day 5, and then you can start the stimulation of all the patients at a time. So those who are doing batch IVF should continue till the day of stimulation, irrespective of the day of the menstruation. In some it may be day 2, in some it may be day 3, some it may be day 4. But if you start stimulation, you can get a good cohort of follicle. The whole advantage of this is that you have not done agonist down regulation, and that is why agonist can be used as a trigger. So those who are the beginners, particularly the PCO patients, then please never use GnRH agonist down regulation because you won't have any option of agonist trigger, and you will have to give HCG to the patient, and you can invite OHSS. That's why the agonist down regulation should not be used now in a routine practice. Agonist down regulation, instead of people are using it only also for the endometriosis. But the ideal treatment at present of endometriosis is that you do the pickup, and before transfer, you can give depot preparations for 2 to 3 months so that will remove the progesterone resistance, and then you can transfer the embryo afterwards. So it is not preferred for down regulation, and it should never be down regulated for IUI cycles. For IVF also nowadays we are not using it, and because it increases the complications and the cost to the patient a lot. The use of GnRH agonist for the final maturation with conventional luteal support and fresh transfer is not recommended in IVF ICSI population. So when you give agonist trigger, then many times it may cause the luteal phase defect, and that's why normally we freeze the embryos and transfer in the next cycle. But suppose it is not possible, then you can give estrogen progesterone to these patients, and you can do the fresh transfer also. With imminent risk of OHSS, all embryos can be freezed and transferred in the subsequent cycle that results in excellent pregnancy rates. A recent large retrospective analysis of Engage, Ensure, and the Trust trials found that threshold of 19 follicles of more than 11 millimeter on the day of trigger predicted severe OHSS with 74% sensitivity and 75% specificity. That's why you always give reserve agonist for a trigger. That is a fundamental rule for prevention of the OHSS. Ovarian drilling. It is considered the second line of treatment. It is the first line of treatment when laparoscopy is indicated for the other reason. It is an excellent procedure. We have more than 2,500 pregnancies by this time with the ovarian drilling. It can be used instead of gonadotrophin therapy, or even in a recurrent pregnancy loss also it can be used. Destruction. What is the mechanism of action? That you actually destroy the stroma. You don't puncture the follicle. You destroy the stroma. By destroying the stroma, the stromal cells will be decreased. That will secrete less androgen, and that decrease in androgen, the LH level will decrease, and the decrease in LH will automatically rectify FSH-LH ratio, and that the LH will decrease, the FSH will be more, and the ratio that will give us spontaneous ovulation. So that is the mechanism of action of ovarian drilling, is the destruction of the stroma. And that gives a monofollicular development. It outweighs all other benefits. And Howard Jacob says that ovarian drilling is an excellent procedure. And sorry, 12 months of pregnancy rate after the drilling and 6 months of gonadotrophin stimulation, the pregnancy rates are same. So, and the main thing is that the effect of drilling lasts for 9 years. The customary teaching was 6 months to 1 year or 2 years, but it has been Howard Jacobs, and they've said that the effect lasts for almost about 9 years. And that's why the re-drilling should never be done when the patient comes to you after the first pregnancy, after 2, 3, 4 years for the second pregnancy, then they never do the re-drilling. The original drilling always works. So that works for almost about 9 years. Evidence-based medicine has proved the drilling to be better than gonadotropin for the PCO patient. So that's why I always think of ovarian drilling for the patient. The question is only to whom you should drill. The most contraindication is PCO-like ovary. Many patients, they just look at the ovary at the time of laparoscopy. This is very common. Those who are asking for freelancing laparoscopic surgeons, they come and they just see inside that the ovaries are like PCO, and then the drilling is done. So I always tell that you should write down the stromal volume and ovarian volume on the case paper, or you should go for the insulin resistance test, that is fasting insulin level, fasting sugar level, give 75 grams of glucose and measure the glucose and insulin level. In all these patients, the glucose level will be normal, but insulin level will be very high. These are pure cases of insulin resistance. These are the patients where the drilling should be done, and you will never across a single case of ovarian failure if the insulin levels are very high. So you measure the ovarian area and you measure the stromal area. This can be measured with the help of an ultrasound, and then you can decide whether which patient requires drilling or not. Here you can calculate the stromal area, you can measure the ovarian area, and you can deduct from the follicles, then you can know the stromal area of the patient. The three-dimensional 3D ultrasound has the potential to address these points and improve the sensitivity and specificity of the ultrasound in the diagnosis of PCO. Both total ovarian volume and the stromal volume during the early follicular phase are significantly higher in the woman with PCOS patient. Now, the question is only about the number of punctures. And I think so many years, the people only went for 4 punctures. But from the very beginning, I tell you my experience of that I have never done less than 15 to 20 punctures in an ovary in a PCO. If I have to do less punctures, I will not puncture the ovary at all. And the reason is that the Stein Leventhal in his original paper in 1935, he said that larger the ovary, the larger chunk of the ovary should be, a larger chunk should be removed. Smaller the ovary, the smaller portion is to be removed. Like 4 punctures, he never said that 2:1:1 should be removed from whatever is the size of the ovary. No. The amount which is to be removed should be according to the size. The same way, the number of punctures should be according to the stromal volume or according to the size of the ovary. And so that is why the number of punctures should depend on the bulk of the ovarian stromal volume. And we go, even here I have gone up to the 40 punctures in such a large ovary. And by clinical calculation, I would say that we always measure the stromal volume. This is my study which we had undergone. And here you can see that with drilling, the pregnancy rates are very high. Time taken for pregnancy is also very low. And initially, people used to refuse for the number of punctures, but from 2009 onwards, there are a lot of papers came that you do the drilling, so you do the AMH of the patient, and after ovarian drilling, the AMH should decrease. If the AMH has not decreased, it means your drilling is not proper. So your destruction biology in this one was not enough. So that's why the AMH has to decrease. That should be the sufficient damage has to be done inside the ovary. And that is only possible according to the number of punctures when the ovaries are larger. This is another paper that came in 2011 that measuring the AMH and ovarian stromal 3D power Doppler blood flow for the woman with anovulatory PCOS undergoing ovarian drilling may provide a useful tool in evaluating the outcome of an ovarian drilling. So it is a X-ray SRM recommendation. Second line of therapy like Gonadotrophin in Letrozole resistant cases. If laparoscopy is indicated for some other reason, then it is the first line of treatment. Risk and cost should be discussed. HIFU, the larger studies are required. It cannot be given to all the patients. And last is IVF for IVF. I told you IVF is regarded as the third line of treatment. Single embryo transfer, it is preferred. OHSS and multiple pregnancy is the hazard apart from the cost of IVF. Anovulation is not an indication of IVF. ERT is done in PCO patients with associated pathologies, and IVM can prevent the OHSS. GnRH antagonist protocol is recommended for PCO patients and is preferred with the high responder woman with regard to improve the safety and equal early administration of antagonists reduces the incidence of moderate to severe OHSS. It gives better pregnancy rate due to synchronization of the follicle. It reduces the LH and E2 in the early follicular phase. Choice of FSN does not differ in the pregnancy rate, but I told you there are lots of controversial papers, but I would never add LH in a patient of PCO where the LH level is already high. So LH supplementation should not be done routinely in IVF patients. Antagonist protocol is preferred over agonist. HE is best used at the lowest dose to trigger the final oocyte maturation, and that's why we go for the dual trigger. That is, we go with the agonist trigger, and for the completion of meiosis, we require 500 to 1000 units of HCG. So give 1000 units of HCG and agonist trigger, both combined together will never give you the OHSS. And that's why you can freeze all the embryos and you can transfer in the next cycle. Metformin is only particularly when you want to go for the fresh transfer, otherwise it is of no use. IVM may be the future for OHSS. So this is the last segmentation of ART that optimize the ovarian stimulation with antagonist cycle, vitrification or optimum cryopreservation of all the embryos, and embryo replacement in the non-stimulated receptive endometrium should be done. Freeze all late OHSS is prevented and it does not affect the results, but the data to freeze in a regular patient is still not available. X-ray SRM guidelines, IVF is the third line of treatment, effective, and the single embryo transfer can minimize the multiple pregnancy rate. Risk, cost, and benefit should be discussed with the patient. Antagonist protocol and agonist triggered with freeze-all can avoid OHSS completely. Exogenous LH is not required in PCOS. All FSH preparations have given the good results. HC should be used in the lower doses. Freeze-all must be considered. Adding metformin may prevent OHSS. IVF is offered in clinics which are expertized. Kisspeptin, triggering the final oocyte maturation with this peptin is the novel therapeutic option to enable the fresh embryo transfer even in the woman with the high risk of OHSS. Kisspeptin results in a shorter duration of the LH exposure. Second dose of kisspeptin is given after 10 hours. It yields the better pregnancy rate and better number of oocyte. So the future is kisspeptin. Perhaps the trigger will be possible with the kisspeptin and the OHSS completely can be omitted. Kisspeptin and neurokinin B modulate the gonadotropin secretion in PCOS patient. It modulates GnRH and ILH secretion by mediating estrogenic feedback. So kisspeptin will be the future for all. IVM, I think still it is experimental, and the ASRM and all the guidelines, they say that there is no sufficient data is lacking, and still it is very much experimental. So just I summarize my talk. Weight loss is the first line of treatment. Letrozole is a drug of choice. Metformin may be added in CC-resistant patient and avoid OHSS. Glucocorticoids may be useful in CC-resistant PCO and chronic anovulation. Gonadotrophin, ovarian drilling is the second line of treatment. Chronic low-dose protocol, FSH protocol is ultimate. Agonists may be used for the trigger. Antagonists are very useful in thin, lean PCO patient. IVF is the third line of treatment, and IBM is the alternative future management. Thank you very much.
Thank you very much, sir, for elaborating us on all the nuances in PCOS management, firmly erasing all the older protocols and imbibing in us the latest recommendations. Thank you, Lord, sir.
Thank you.
Sir, one doubt, sir.
Yes.
In case of a resistant PCO with only withdrawal bleeding, the maximum days of letrozole you're telling is only 5 days, sir, for ovulation induction.
So I told you, now there is only one paper on 23 that is in fertility sterility that you give it 5 milligram. More than 5 milligram should never be given. You can increase the day from 5 milligram for 5 days, then you can give 5 milligram for 7 days, and then you can give 5 milligram for 10 days. But I would prefer to add the gonadotrophin from day 7 onwards. Those patients who can afford gonadotrophin, then I will add the gonadotrophin. But there are patients who cannot afford that, then I would like to take an advantage of longer duration of gonadotrophin, longer duration of letrozole rather than adding gonadotrophin to these patients.
Sir, regarding drilling, sir, whether it can cause a very rapid fall in AMH?
Within, I think you can do it after a week only, the AMH will be quite low. But we normally do it after 1 month because we start the therapy after the 1 month, but after getting the next period. And at that time, we once again repeat the AMH.
She's asking about failure.
Failure of AMH?
No, failure of ovarian failure.
No, we never get. I told you that if you stamp the patient as a PCO patient, then the ovarian failure will not occur. And what practical purpose, I tell you, the number of punctures that you puncture the anti-mesenteric border and you cover the anti-mesenteric border, then I think the number of punctures will be equivalent to what I tell you according to the stromal volume.
There is a question in the chat box.
Yes.
Letrozole step-up protocol, can we increase it to up to 10 mg? I think you've answered it.
No, otherwise it is only 2.5 milligram. Only 5 milligram, not more than 5 milligram should be used. There is no evidence based. And those which was step up 1, 2, 3 and 4 tablet, that was 2009 paper is not accepted because if you want to go for multiple follicle, why not to use clomiphene rather than, which is 50 or 100 rupees, rather than 3,000 rupees of so many letrozole tablets.
Yes, sir. There is another question from Dr. Sharada. External letrozole if no follicle development after seeing on day 11.
No. You give it for 10 days, then you have to wait for up to 25 to 30 days. For the whole month you have to see, because the follicular development will be afterwards, after a week or so. So from 11th you cannot start. But we normally what we do, we give 2.5 milligram from day 3 to 7, and day 7 onwards, according to our scoring system, we start the gonadotrophin to the patient.
Yes.
See, I tell you that we never like to waste the month, because patients are always, they have fixed number of months to be treated by you. After a few months, if they don't conceive, they will leave you. They have got a lot of options available to them. And that is why don't waste your time. These are the trials. That is for an institution or where the patients are poor, then you can afford to go for these trials. But otherwise, in a practice, I always prefer to start gonadotropin from day 8 onwards, so that I get a follicle and I can do it accordingly.
Any other questions anybody wants to ask? So it was a very nice presentation. I think the dosage of gonadotropins is always a trouble for doctors to decide. So we can see from the chart, and then once we start doing the Doppler, I think from 37.5 we can avoid OHSs and multiple pregnancy while starting it. We are also using the similar protocols and we are getting good results. So I think any other questions, Dr. Angamal, madam? Anything else you wanted to ask? I think she's not able to unmute.
Madam,
Yeah.
it's regarding, wanted to know about fresh transfer in PCOS after minimal dose protocol, a low dose protocol.
Same cycle, embryo transfer in the IVF cycles.
After minimal dose protocol.
You can do a minimus dose protocol, and then you can do the fresh transfer. Then normally, if you have given an agonist trigger, then you require a judicious support. But otherwise, we always go, if you want to do the fresh transfer, then we give the agonist trigger and we give 1,000 units of HCG to the patient. Because when you give your 10,000 units in your IUI cycle, then 500 units are required for completion of meiosis, and 9,500 units are for the rupture of the follicle. Here in IVF, you don't require rupture of the follicle. So by 500 to 1,000 units of HCG will complete the meiosis, because sometimes agonist trigger may not have an LH surge. If the patient is hypothalamic amenorrhea, or the patient is having an OC pill since long, for few months the patient has taken the OC pill, then LH surge will not occur and you may get an empty follicle syndrome. So that's why we always give a dual trigger to the patient, that we give 1,000 units of HCG and then we give this to the patient. So even if the number of follicles are more, then also there is no problem. It does not go to OHSS. And here in a mild stimulation of OHSS also, you can give 1,000 amount mild stimulation in PCO, that you can give 1,000 units and agonist trigger. Then the paper which I had given, I had shown, is having 53% pregnancy rate. So pregnancy rates are very high. You can give estrogen, progesterone support, and your 1,000 unit is going to rescue the corpus luteum also.
Okay, sir. Even when we document a lower LH, we are not supposed to use HMG, sir, in PCOS.
Normally the LH level is always high in a PCO patient. So you stem the diagnosis, whether the patient is PCO or not, either by Rotterdam criteria or by your ultrasound, you can diagnose that it is PCO. But then I always go for insulin resistance or the 3D volume. What is the stromal volume? Even a stromal area, when it is more than 34%, it is 100% PCO. So in a PCO patient, I will never use HMG. HMG is normally used in a regular patient after 35 years of age, because the bioactivity of the endogenous LH may be poor in some patients, or there may be LH polymorphism may be present. So in these cases, your previous cycle has not given you the expected result, then you would like to add LH to the patient. Otherwise, the routine LH supplementation is not required, because the amount of LH that is required is very small quantity. Even by agonist down regulation, also small amount of LH is always there. Even 0.1 is enough for the development. So the HMG is used in India most of the time because it is 100 or 200 rupees cheaper. And that is why people are using HMG to all the patients. But in a PCO patient, I strongly contradict that the HMG is not to be used, only FSH is to be used.
Thank you, sir.
I know so many examples because the people do ring me when they get any difficulty from the different centers. One of the center I still remember why they phoned me that there were 24 eggs and they got only 4 M2s. Now she asked me what was the reason, and then I asked about the stimulation. The stimulation was by HMG. So you are adding more LH, and where you are adding more LH, it is going to destroy the quality of the follicle. So your quality will be inferior. You don't gain anything. Just ask yourself that are you gaining anything by adding LH? Then add HMG. If you are not gaining anything by LH, then use only FSH.
Thank you, sir.
Thank you, sir. Thank you for the time and almost an hour session. So thank you for all the energy and your inputs. Thank you. We'll catch you up for the another meeting.
Sure.
Thank you. Thank you.
Thank you,
very
madam.
much.
Thank you, madam.